Okay, great. So we'll go ahead and get started. So good morning, good afternoon, and good evening. Thank you for joining us today for this Path Life Forum, where we'll be discussing the future of primary healthcare as the central strategy to achieve universal health coverage by 2030, and how we can reimagine PHC through proactive design, adaptive and differentiated models, use of technology, and innovative ways to expand diagnosis and management of healthcare needs. My name is Dr. Kimberly Green, and I'm PATH's Global Director for Primary Healthcare, and I am delighted to be moderating this conversation today. So we'll start first by going over some logistics. We want to hear from all of you during this conversation, so please share your questions and comments with us by submitting them in the chat or the Q&A box at any time during the discussion. I'll be monitoring your questions, and we'll be saving time at the end of the hour for an audience Q&A. So speaking of questions, to frame our conversation, I'd like for you to share one critical barrier to ensuring access to high quality, equitable primary healthcare. So if you can think of the key barriers that you see in your daily work, please type your answer in the chat box and hit send to everyone. That's really going to help the panelists and also help our Q&A towards the end of the session. So a final note on logistics, this call is being recorded and will be distributed for those that are unable to attend. I see we have participants joining us from all over the world, government representatives, community organizations and NGOs, donors, as well as private sector partners and others. Thank you for joining us. As an overview for our session today, I'll introduce our panelists and then briefly frame the conversation before diving into a facilitated Q&A with each of our panelists. So we are honored today to be joined by a stellar group of health leaders and providers, researchers, social entrepreneurs, and human-centered design specialists. We have with us Her Excellency, Dr. Leah Tedesse, who is the Minister of Health of Ethiopia. Dr. Leah has been the Minister of Health for Ethiopia since March 2020, really since the beginning of COVID-19, and is known for her superb management of the COVID pandemic within Ethiopia, while at the same time assuring access to essential health services. So we're looking forward to hearing from her about that experience. She previously was the State Minister of Health, and before that was Program Director at the University of Michigan, and also CEO and Vice Provost for St. Paul's Hospital, as well as a Project Director for JPIGO. Our second panelist is Dr. Julian Atim, who's the Clinical Research Lead at GH Labs. She brings nearly 20 years of experience that span clinical care in rural hospitals, healthcare quality improvement, and health product innovation and introduction. She's worked across many different sectors to help to strengthen health service delivery in Uganda, Southern Sudan, Ethiopia, Mozambique, and Nigeria. Our third panelist is Mayank Sharma, who's Senior Program Officer who leads on primary healthcare at PATH. Mayank is a member of PATH's primary healthcare team and comes to PATH from the Ministry of Health and Family Welfare in India, where he served as the focal point for primary healthcare. And our fourth panelist is Dr. Radha Karnad. She's the Chief Medical Officer for HealthX Africa. She's a healthcare leader with 15 years of experience in developing innovative approaches to clinical medicine in hospital and community settings, healthcare program management, quality improvement, and human resources for health, working across the US, UK, and East Africa. As the Chief Medical Officer for HealthX Africa, she works with a group of providers across many different health specialties that offer high quality and affordable primary health care across Kenya through digital health solutions. So thank you so much for being with us today. We are grateful to have our stellar panel with us for this compelling conversation on primary healthcare innovation. So now I'd like to frame our conversation for today. I'm moving into the next slide. And next slide, please. Thanks. So we know primary healthcare is effective when it is accessible and it is of quality. And we know that primary healthcare is the expressway to achieving primary healthcare to achieve universal health coverage by 2030. Primary healthcare represents 80 to 90% of care that individuals seek in their lifetime. And studies indicate that primary healthcare leads to better health outcomes, improved health equity, increased health security, and better cost efficiency, making PHC the cornerstone of health system strengthening, as well as the foundation for universal health coverage. Next slide. So despite how powerful and how effective primary health care is, go back to the previous slide, please. We know that primary health care, there's been insufficient investment, which leads us to be significantly short of the Astana Declaration stated goals and also of the SDGs. And this is primarily because of limited investment in primary health care, fragmentation, in some cases reactivity, and also in some cases top-down design. And as a result, only 50% of the world's population has access to essential health services. And every year, nearly 100 million people fall into poverty because of health-related expenses. And next slide. So this really leads us to what can we do? Knowing these challenges for primary health care, knowing how essential primary health care is to achieving universal health coverage by 2030, what do we want primary health care of the future to look like? And how do we design for it? And what is the role of innovation and partnership then in designing primary health care? So next slide. So at PATH, we've done a lot of thinking really about our focus for primary health care. And really that's led us to prioritizing accelerating person-centered primary health care through innovation and partnerships across 3 core objectives: advancing tailored primary health care services that meet individual and community needs, catalyzing optimally resourced primary healthcare systems, and finally, strengthening primary healthcare capacity to resiliently respond to health threats like COVID, like AMR, and like climate change. And next slide. And so really speaking of health threats and really considering COVID-19, with responses to COVID-19 across many countries, we saw some significant innovation and adaptation that happened, particularly with primary healthcare service delivery. And so there's a lot of interesting learning that happened, particularly during lockdowns, and in some countries is carried forward to be scaled up. And that includes use of telemedicine, access to self-care tools and technologies like self-testing, integrated services, those that are bundled to make them more accessible, partnerships with pharmacies, for example, and other ways to offer people-centered innovations. And next slide. So even though there's quite a lot that we can learn from related to service innovations, there still are gaps in terms of access to the right products, diagnostics, and digital tools that would truly enable access for primary health care. And so there's been efforts across a number of stakeholders to really map out what is needed and what are the gaps. And one of those efforts was led by the PATH India team, and you'll hear more from Mayank on this. But really, I was looking at what's out there and what could we make available through primary healthcare settings across these different technological gaps. So with that, I would like to turn to our panelists to really consider all of these factors related to primary healthcare, thinking about new design and what we want in the future. And so we're going to have 2 rounds of Q&A. The first round is going to focus on key learnings from COVID-19 and current healthcare realities that inform innovation. And so I'm going to start first with Dr. Radha. So Dr. Radha, you are a very strong proponent of primary healthcare and see many opportunities for innovation and changing the way in which PHC is delivered, including through telemedicine. Tell us more what HealthX Africa is doing and why telemedicine is a key area of innovation and growth in increasing access to quality primary healthcare. So over to you. Oh, Dr. Radha, okay, now we can hear you. That's great. Go ahead.
I'm sorry. Everything froze for a minute. My name is Radha Karnad, and I'm the Chief Medical Officer at HealthX, as Kim said. And Kim, we are, HealthX exists really to deliver on the promise of primary healthcare in Kenya. We believe in the vision of a doctor for every Kenyan, and we believe that technology actually can make that help to make that possible here. It's a very exciting time in Kenya, and I think COVID really facilitated the growth of this space here. Pre-COVID, so 2019 or before, there were probably one or two at the most at any given time service providers trying to look at telemedicine as a way to deliver services. It wasn't really regulated. There wasn't a lot of power or belief behind it. Including from the medical fraternity and the regulatory bodies, and COVID has changed that completely. So in the last 2 years, the Kenya Medical Board has taken on the responsibility of regulating telemedicine, and we now have, we believe, over 50 registered telemedicine providers of different sorts, from specialists down to really community-based models of telemedicine. And that doesn't even count a huge growth in sort of unregulated, unregistered models of telemedicine that are being tried out. And I think what's been very interesting and exciting is that telemedicine, in Kenya at least, there's this realization that telemedicine actually can help us to achieve the vision of UHC that the government has committed to. A large part of that is that although digital literacy rates are quite different across the country, it is a hugely connected, digitally connected country. So cell phone or mobile SIM penetration rates are around 132%, which means most adults have one, if not two or three SIM cards. And whether we're using that on, a smartphone or just for texting or on a feature phone, people are connected. People do have that ability to connect. And so where it falls to telemedicine then is to figure out what is the best technology to actually connect to them. And that's very, very exciting. In the same way, I think there's currently almost every mobile phone. So there's like a 90% internet penetration through mobile phones. And we use them in Kenya across every other sphere of our life. So we use them obviously for communications, but for banking, for education, for socialization, for shopping. Really in every sphere of Kenyan life, people are using their phones except for healthcare in a sort of really structured way. I think what we do see very often, and people getting more and more used to, sending a message to their doctor, sending a message to their local village midwife, sending a message or making a call to their community health worker. That's been happening for a long time, but there hasn't been a structure and a system around it, and that's really changing. There's a huge push from the government that's allowing that to happen now in a way that feels much safer and much more structured in terms of setting up, bills and legal frameworks for what telemedicine or digital health will look like. And I saw some comments around that being a big barrier. I think that's true. And also around the standards that we need to be meeting. When we set up HealthX, none of that existed. And so we started off really as a small clinic with a belief that our doctors had the ability to do more. So we added on telemedicine. Now we offer 24-hour telemedicine services around the country. We reach clients in 22 different counties of the 47, as far as we can tell from our records, maybe even more. And 85% of our callers don't use our app. They don't use the exciting and fancy tech that we have. They use our toll-free number. They use a feature phone, but they get a really high-quality primary healthcare consultation. Most of those, between 80 to 90%, get managed completely by our service. So it's only 10% who end up, needing a referral, needing to actually access a facility. And we're getting a lot of feedback from users that is such a change in their experience, where they would have to take time off and travel, pay for all those services, pay for time for childcare and the rest. They now can just pick up a call and speak to a doctor, and that's really changing things here. So it's a very, very exciting time. And yeah, happy to be here to talk about it.
That's wonderful. Very exciting indeed, and really interesting to hear about the opportunity for telemedicine with such high use of mobile phones and really strong preference for more convenient healthcare. So I'd like now to turn to Her Excellency, Dr. Leah. Ethiopia is a global leader in primary healthcare with a system that's designed to be responsive to what communities need and want. That started more than 50 years ago, so really ahead of pretty much everyone else. You have a strong community workforce, the health extension program, and a linked community and national health insurance scheme that has become the prototype for many other countries. So how did the system stand up to COVID-19, and what are key learnings from the COVID-19 response that you plan to take forward in future design and delivery of primary healthcare? Over to you, Minister.
Thank you very much, Kimberly. It's a pleasure to be in this panel discussing this very important topic, and thank you for the kind words on the system we have. Indeed, we have, as a country, Ethiopia has invested a lot on building a strong primary health care with, of course, a community health system with health extension workers at its center. And of course, the pandemic has been both a threat, but also an opportunity to show us where our weaknesses are, but also build on the strong components we already had built on. In the beginning of the pandemic, particularly, we had seen disruption of services like any other country, but I think one of the key learnings was we were quickly able to bounce back to the baseline services that we've had in a couple of months by reorganizing ourselves, not just for the response, but for the continuity of essential services using our primary health care. And we are also able to use our community health workers to both address detection and awareness within the community for COVID, but at the same time, reaching to communities to avoid disruption of chronic illness services, maternal reproductive health services, and ensure linkage to our primary health care centers and health posts so that we avoid more loss from other issues other than the pandemic. And we are also able to use, of course, our primary care healthcare system, including our health centers, for isolation and some of them for treatment centers. And of course, once vaccination was started, of course, to use vaccine delivery, we primarily used our primary healthcare centers and that platform that we have, including, of course, using campaigns. And we have definitely seen that a strong primary health care has been key, and even for the way forward, to invest in a strong primary health care is key for resilience, both on having the right mix and training of health care workers, but also having a right surveillance system at the community level, community surveillance and epidemiologic surveillance system linked to our public health emergency response system. So it has helped us reorganize ourselves from the national to the subnational structures in terms of the emergency response. But also it was an opportunity to look at building our system in critical care and emergency care, starting from primary services, but also all the way to the different levels of care, which we try to use as an opportunity in investing in those systems as we move forward. And of course, the other key learning has been the issue of collaboration and solidarity within country and of course beyond country, regionally and globally. We have seen at the local level how it was important in such multi-sectoral emergency issues. It's not only the response of the health system. We have to have a very strong multi-sectoral coordination, which was done both at government level, but also with the society, with the community, using volunteers and other players within the private sector and academia and others, both for resource mobilization, but also community awareness and other responses. Even using makeshift facilities was key in our response, and this was possible by very strong coordination. So the whole of government, whole of society for emergencies was really one of the key foundations we have learned on, but continuing really to invest in these key pillars as we move forward. And not just investing on of course, our primary healthcare system, but also the way we finance our primary healthcare system has been one of the key learnings as we move forward. Because one, as you mentioned, our health insurance system has been a key in improving our care, but it's still on the process. We are yet to make it a universal one. We have reached around 45 million through our community-based health insurance, people covered, but it's yet to continue. But also how we invest in our primary health care, both as government and using our other resources from our donors and partners but also the financing mechanism for primary healthcare system to make it more efficient is what we are looking at in terms of performance-based financing, capitation, and others which we are piloting. So this was all possible because of the different challenges we've had through the pandemic. But one thing I have to mention before I finish is also the opportunity of digitization. We have used the opportunity. For example, one of the key expansions we did through the pandemic was our lab system, but not just expanding testing capacity, but also making sure that all facilities are connected with our National Public Health Institute to make sure we have real-time data to follow such a response. So we are looking at how to expand now the digital health in terms of really improving the efficiency, equity of care that we can provide at our primary healthcare system. Thank you.
Thank you so much, Minister Leah. It's so wonderful to hear directly from you about what's known as a great success story and how Ethiopia responded to COVID-19 on so many levels, which you've articulated. But really, we're able to do that more effectively, perhaps, than other countries because you had that strong foundation of primary healthcare and strong leadership coming together. And it's wonderful as well to hear about the multi-sectoral approach, the role of the community, the private sector, and how you're applying your learnings forward on financing and digitization. So thank you for that. Now, related to some of the innovations that Minister Leah shared with us, I want to turn to you, Dr. Julian. You know, GH Labs is all about design as a pathway to innovation and impact. And so through your work, you're looking at combined user-centered design and tech to bring to market new solutions for primary healthcare. So please tell us more about what challenges you're working on right now that could have an impact on the way in which primary healthcare is offered. So over to you, Dr. Julian.
Thank you. At GH Labs, we innovate to reduce health disparities, developing tools and technologies that meet unmet need to strengthen patient outcomes, especially in PHC in low to middle income countries. Our work involves research in a lab based in the greater Seattle area, but most importantly, we also work with partners and direct collaborations in country, in India and across Africa, where PHCs was having gaps in needs. And to do this, these collaborations ensure that our technologies genuinely reflect and serve the people who need it, ranging from the providers themselves, the patients, as well as some of the key stakeholders that designers don't think about, who are very critical in influencing access to these solutions, especially in these countries based on the design of how access is influenced. We do this by applying design and development techniques that not only surface, but are also centered around the needs and desires of the users and the key stakeholders. And this eventually helps in ensuring the solutions are feasible and have sustainable usage where they are supposed to be used once they're ready for deployment. As an example, based on understanding the needs and thinking about what happened during COVID, we learned that having more diagnostics at the lowest level is very crucial. And currently we are working on point-of-care molecular diagnostic test platforms, which could expand diagnostics access to some of these lower health facilities that usually have to refer their samples for certain conditions. And we think this will be a game changer for some conditions that have problematic diagnostics like STIs. It's based on that we believe that our novel diagnostics hold a specific promise to leapfrog some of the barriers, such as expensive lab infrastructure, to bring diagnostic tech within the reach of the providers at the point of care so that they can be able to make prompt decisions and provide prompt treatment and appropriately to the patients. I'll end by saying that in thinking about user-centered design, we believe this is very critical because if it's successfully prioritized, it will help sustain usage of these tools by the providers not only improve the clinical outcomes of the patients, but also enhance their satisfaction and belief in the health systems, which is a very critical pathway for use of these tools at scale, not only to improve outcomes and impact at country level health systems, but eventually to have a global level impact. Thank you.
Thanks so much, Dr. Julian. Yeah, so really emphasizing how important it is to understand what people who are seeking healthcare really need and want, and also the providers and health managers, so they get used and they get financed. And very exciting to hear about molecular testing, including for STIs. That truly would be game-changing for people to access an easy diagnosis and treatment. Before I turn to Mayank with the last question for this first section, I wanted to see if anyone has questions. You're very welcome to post those in the chat. We'll look forward to addressing questions towards the end of the discussion. So now turning to you, Mayank, bringing it all together, India has made major commitments to primary healthcare, including through the Ayushman Bharat scheme. And as part of this, Path India is supporting 2 primary healthcare innovation hubs, one urban and one rural in Maharashtra. Can you tell us more about how you're pulling on these different threads of innovation to be more responsive to what communities need, including investing in primary healthcare prototyping through human-centered design, additive diagnostic and treatment capabilities, and also telemedicine? Over to you, Mayank.
Thanks, Kim. Hello, everyone. So this is a great stage to discuss and share perspectives on the next generation health systems, especially in the wake of the pandemic, which is not yet over. As many of the panelists also have spoken, there is a growing consensus among the informed that resilient health systems geared for a future pandemic can only be made on a strong foundation of primary healthcare. The government here in India has also outlined its shift from a selective to a comprehensive primary healthcare in its national health policy. To fulfill these commitments, as Kim just mentioned, the Ayushman Bharat was launched. It has now 4 pillars. These are the Ayushman Bharat Health and Wellness Centers, which creates a network of 150,000 health and wellness centers. These are responsible for providing comprehensive and integrated primary healthcare to the last mile. And there's the Prime Minister's Ayushman Bharat Health Infrastructure Mission, which was recently announced as part of a World Bank loan for creating a network of laboratories and strengthening surveillance to detect newer pathogens. This also supplements creation of health and wellness centers in the urban areas, which were not yet funded. So the third one being the Prime Minister's Jan Arogya Yojana for inpatient hospital expenditure. And then the last one being the Ayushman Bharat Digital Mission that aims to create this backbone necessary to support the integrated digital health infrastructure needs. So we at Path understand this needs a multi-pronged strategy based on partnerships and innovations, and with a strong foundation of comprehensive primary healthcare. And we've been closely working with the states and the national governments in these initiatives for fast-tracking implementation, and as well as providing the necessary technical support. As Kim pointed out, we are implementing a rural comprehensive primary healthcare demonstration project in one of the districts in the state of Maharashtra. This project will act as a springboard for priming innovations for scale. How we did it was, first we did a comprehensive assessment to understand the gaps. We have also partnered with organizations like Final Mile to provide behavioral science and human-centered insights to enable these health and wellness centers to act as hubs for care. We have completed the first phase of this work and have developed a behavioral understanding of the demand and supply enablers and barriers. Soon we will start with the second phase, that's the iterative design, research and solutioning approach, understand and design and prototype interventions across some of the key focus areas. We are closely working with innovators to scout for key innovations that can accelerate the progress towards universal health coverage. So based on the gaps that were identified through needs assessment and continuous iterations with the implementers, innovations were selected for deployment with a focus on increasing access to primary care. Many innovations were present even when the COVID hit and was scaled up. One of the best examples from India was eSanjeevani, the national teleconsultation platform. Path, along with other partners, helped in the operationalization and activation of these eSanjeevani teleconsultation platform. And it's now closely activated in close to 110,000 health and wellness centers across the country. This platform is being used to provide specialist consultation via the hubs and thus reducing travel time and cost of care. We have partnered with key organizations and conducted the PHC Tech Challenge, the slide for which was shown in Kim's presentation. This happened last year with an objective of providing a platform promising medtech, digital, and cold chain innovations to key stakeholders. This selection process involved, and close to 115 applications were received, and finally 17 winners were selected with most potential to create significant impact. Some examples include a wireless temperature monitoring system for cold chain equipment and affordable smartphone-based ultrasound. So this is publicly available, and I'll copy the link in the chat so that every one of you can go through these innovations. Already multiple innovations have been deployed for screening and diagnostics. As part of the support from Digital Connected Care Coalition through Philips Foundation funding, we have also deployed Smart Stethoscope. This device aims to reduce the burden on healthcare workers in villages. Similarly, telehealth monitors are being deployed that can measure a range of basic vitals and through a point-of-care lens. These are through self-administered tests, and the readings can be wirelessly transmitted to a specialist. Then there is a novel software-based medical device which can detect breast cancer at a much earlier stage than traditional methods. Interestingly, this imaging method is radiation-free and does not involve any touch and is perfectly ideal for remote clinics. We've also been able to demonstrate use of professional antigen RTTs in remote facilities for quicker testing of COVID-19, along with artificial intelligence-based chest X-ray interpretation for real-time flagging of tuberculosis, COVID, and other lung conditions. With support from Google, we have also deployed portable spirometry point-of-care devices for early detection of COPDs and asthma. There's a long way to go, we understand that, but as India assumes the G20 presidency this year, it is also a great opportunity to scale up technology that can transform healthcare, especially in areas like climate change, digital technology. Thank you.
Thank you so much, Mayank. It's really exciting to hear from you and to see how it's all coming together with so many different innovations in one. So now we're going to move to the second round of questions focused on opportunities to pilot and scale innovative primary healthcare. And so we'll start first with you, Minister Alia. Given the impact of COVID-19 on healthcare access, Ethiopia's commitment to achieving UHC by 2030, and also changes in healthcare preferences among younger populations, what are opportunities you see moving forward to innovate in primary healthcare in Ethiopia to continue to increase access and uptake? Over to you.
Thank you. Yes, indeed. As we envision to achieve UHC, again, the foundation is still the primary healthcare, and we still have a lot of homework to do in terms of really having the kind of primary healthcare we need with equitable access to everyone. So we're still trying to focus on addressing equity issues where we have diverse kind of communities and geographies, as you may know, in terms of pastoralist communities, which are hard to reach. So we're looking in terms of the expansion itself, but also on modalities that are more geared towards the type of living situation communities have. For example, the use of mobile teams for such pastoralist and mobile communities. But of course, also at this point, we are also passing through different challenges. As you know, beyond the COVID, we've had many communities affected by conflict and our health system affected. So restoration of those health systems and primary healthcare services to ensure continuity and reaching the vulnerable communities is a priority. But beyond that, also one of the key issues we are looking at the primary healthcare is we have to be close to the community in the package of services we deliver. So we had done an assessment of our health extension program after around 16 years of delivering the program, and have seen that the need from the communities have increased, the demand of the communities have increased. We have had epidemiologic transitions of more NCDs now. We are seeing, of course, we still have challenge of communicable diseases, but the rise of NCDs needs to be addressed at the primary care level, which has been usually even the screening is very limited, but also the care is at higher hospital levels. So what we are trying to do is having the integrated service delivery model within primary healthcare system, which includes screening for cancer and other NCDs and giving the basic treatment at health center and primary hospitals, but also we have mapped our health extension program facilities, which we call health posts, to be divided into comprehensive and basic, where some of the facilities which are further away from health centers can provide diverse package of services with more professionals beyond health extension workers, with health extension workers focusing on the outreach services and strengthening the care. So that integrated service delivery model is what we are looking at. But also improving community empowerment in terms of the health, the prevention of diseases and health promotion is a key issue. So we are looking at different ways of community engagement, where we've had what we call women development groups, which we are now expanding in village health leaders also to be part of the health extension program to improve model families that can propagate creating model communities. So, and as part of that, we are looking at the issue of self-care, which is yet to continue to grow in our communities, which includes some self-testing for HIV, for example, and other self-care issues we are looking at. So more really community engagement and empowerment is really key. And the other key issue as we look into improving our care is the youth and adolescents, because most of our health systems, we have a very young population, but most of our health systems are not geared towards the youth. So looking at how we really design our communities and health service delivery to be really adolescent and youth friendly. And the last point, of course, coming back to the digital health, we're looking at really how to leverage the opportunities we have starting from our community health information system, which we are digitizing now into electronic CHIS nationally, and to the different EMRs and other digital platforms we are trying to use to engage communities or empower communities as well. So I think these are the main key areas we are looking at into building stronger health system, but also not to forget, of course, the public-private partnerships that we are trying to build at different levels, because there's a lot we have to leverage through public-private partnership within our systems.
Thank you so much. It's really exciting to hear your thinking about how to extend reach into different communities, including pastoral communities, through mobile services, through extending the role of the health extension workers, and also adding to the package of primary healthcare, really reflecting NCDs, including cancers, hypertension, and so much more. So thank you. It's really inspiring to hear your future plans. So now let's turn to Dr. Julian, and just really thinking about what kinds of innovative opportunities that GH Labs, really leveraging its expertise and its partnerships with different countries, where do you see those opportunities to expand capabilities and reach of primary healthcare through innovation? So over to you, Dr. Julian.
Thank you. For partnerships, we consider partnerships a very important way for us to work and be able to create synergies with entities that have similar goals with our own, to expand primary healthcare and using innovation in health technologies. And this is important because it enables us to leverage their efforts to be able to enhance our own contribution. There are very many different ways that we collaborate and partner with different entities as part of acceleration of innovation and creating impact forward in healthcare. As a partner, GH Labs does several things, including things like sharing tools for innovation, sharing data, IP whenever possible, with some of the innovators we work with to help spur the next generation of discoveries or inventions in healthcare for impact. While we are not a grant-making organization, we are also uniquely resourced with key talent and funding to accelerate the development, adaptation, and sometimes integration of existing novel technologies to enhance their synergies and impact. There are a number of ways. I have about 6 that I can share that we can partner, and what makes us have the talent and funding. Some of them include our ability to self-fund, but also de-risk some of the early stage research and development in our own lab. Secondly, we are also able to not only develop, but also validate these prototypes, like I talked about earlier, in the field where they will actually be used. following to that is also our ability to work with different innovators in PHC by providing technical guidance. We have a lab team with over 70 scientists who can provide critical technical advising to some of the innovators that might not have those resources. And then very importantly, we also provide open access to IP, our collaborating partners, to help accelerate bringing those technological innovations to the places where they are needed most. And then as in some scenarios, we also provide the tech transfer to some of the mission-driven commercial use purposes. And that is where there are some agreements in terms of ensuring that the prices for targeted countries remain within what is acceptable. And then sixth and importantly is that we know that some of our research and development can support innovation elsewhere. And so we publish it as a public good, widely available, that other innovators are able to access. And an example of that is that during COVID, we did some work in antigen antibody pairing that facilitated some manufacturers to be able to use that information to develop home-based tests, and hence increasing access to testing. And then using the example, I'll use an example of one of our work in AI-enabled point-of-care device for improving cervical pre-cancer screening. We well know that this is one of the fourth commonest cancer among women, and 90% of the cases and actually the death are in low to middle income countries. And we believe that besides prevention, using some very effective tools like vaccination, we still have to cater for that group that is still infected. And hence, this is a tool that can be able to support screening and enable test and treat kind of approaches. That way, when a woman shows up and she's found with a lesion, she doesn't need to be referred to get further testing, but then the treatment can have, and that can improve critical survival for some of these patients. This project in particular is leveraging a wide range of partners in order for us to tap on their expertise and enhance our contribution, as well as have the different skills and capabilities. And this is happening with partners across countries in Africa and India. And some of the partners we work with, we don't discriminate, come from academia, technology, governments, including ministries of health and some of their regulatory bodies, policy bodies, as well as some of the implementing partners like nonprofits and foundations. And with that, I want to emphasize that we partner, we feel it's a very critical element of pushing forward innovation for technology. And we are usually very welcome to work with people with whose goals align with our own on particular issues at hand for tech innovation. Thank you.
Thanks so much. Really lovely hearing your 6 priorities and also openness to partnership. I'm sure many on this call will be interested in learning more about your work in GH Labs. We will turn to you, Mayank, and then to Dr. Radha, and I would just ask if you could stick to 3 minutes for your response. Thank you. Grateful for that. So over to you, Mayank. What gets you excited about primary healthcare innovation and the incubator in India? And what do you see as the next phase of opportunities to combine new technologies together for greater reach and impact? Over to you.
Thanks, Kim. I'll probably finish it within a minute or two. So it's an exciting time in the space here in India. Incubators are not just providing funding support to innovators, but are also making available the right kind of mentorship for product development and market access. This includes regulatory requirements, access to research and development, manufacturing, and other requisite supports. Much of these fundings from organizations like Department of Biotechnology, Department of Science, Technology, and BIRAC that's targeted for startups is basically routed through these incubators. Many of them have helped foster the medtech and digital health innovation ecosystem in the country. In fact, a large majority of these technologies supported through these incubators are innovative, point of care, and keeping in consideration the constraints of resources in lower middle income countries. Such medtech and digital health solutions find a good fit in primary healthcare settings. At PASS, we have the Impact Lab, which comes in post the incubators for clinical operational validation, regulatory navigation, and scale-up support. And as far as the priorities, I believe these ideally should be around antimicrobial resistance, climate change, and even more point-of-care diagnostics, because they really sometimes work. Thank you.
Thanks so much. That's great. And then over to you, Dr. Radha. What do you see as the ideal state of primary healthcare? And how do you see us getting there through both new and existing tools and approaches? I know that's a big question, but really love your perspective on it. Thank you.
Thanks, Kim. I think, I've been dwelling on this question a lot, and I think really the vision of, the sort of ideal state of primary healthcare, it's been expressed many times. I don't think that that's changed. How we're getting there is changing, but for me, the ideal state is when the primary healthcare system really is the entry point. That's where it really truly becomes the first level of contact for people taking action around their health, and where that means much more than curative health. It really looks at preventive and promotive care as well, and a better understanding of all of that. We're just, we have not achieved some of those components of primary healthcare in the way that we should have. For me also, the ideal state is one in which the idea that health is a right and equity in health is important, is expressed not just in words, but in actions across our system. So, and by that I mean the legal system, the education system, the work environment, all of those need to live and breathe the belief that healthcare is a right and people have the right to access it. I think when we're starting to live those realities, that's the ideal state for primary healthcare. Networks of care around primary healthcare, multidisciplinary teams looking, for example, at HealthX, we look at preventive and promotive care, we look at mental health, looking at much wider aspects around people's wellness. The incredible expansion of sort of point of care diagnostics, and even changes in medication, changes in emergency access, drone delivery of blood. There's so much that's helping us to move towards really that vision and that definition of primary healthcare as it was. Of course, surveillance and the M&E piece, PHCPI, there have been so many partners thinking about those pieces. How do we measure what we say we're doing, and what does that mean? And how does this look when we say comprehensive? How do we actually build that out? I think those are all systems and tools that are coming into play in different ways to move this forward. I think when the one place across, maybe if we talk about the building blocks of health, for example, I think the one place we have fallen short consistently is financing. We do not yet understand how to do this, how to pay for this, who's going to pay for it, what is the best way to do that. The other building blocks are making more progress, but that's the one that we really
I'm not sure if Radha will be able to reconnect. So what we'll do while waiting for her to reconnect is, there are some great questions that have been posed. So thank you very much for all the participants that have posed questions. And one of them picking up on what Dr. Radha had talked about, which is really making sure that in the future, we're looking at how primary healthcare can do a better job of increasing individual access to tools that they can use themselves for their own healthcare. And that really speaks to self-care. And one of the questions was really around, how do we support community health workers, lay health workers, and individuals to access testing technologies, like, as Minister Leah spoke to, HIV self-testing. So I wanted to see if there's any of the panelists want to respond and talk about how you think we could do better in increasing access to self-care tools in the community.
Kim, I can take a stab at that. Can you hear me?
Perfect.
I'm sorry, I feel like I keep cutting out.
Yes, you're back. That's great. You're back.
Sorry, I didn't know I was away. Oh, I'm sorry about that. I think you know, self-care is a really fascinating space, and I'm going to speak to this, if you don't mind, from a Kenyan perspective. That's the space I know best. But what we have seen is a real, you know, an expansion, as I think globally, in self-care testing and self-care opportunities. I think there are two challenges. The one, it continues to be a feeling within the medical fraternity, and I don't mean just doctors alone, but the wider medical fraternity, that, you know, self-care is going to start to impinge on our roles, or how much we're needed, or how this works, and I think that is a big challenge actually to the scale up, because we're not promoting self-care to our patients in the way that we should be, you know, from sort of ministries of health down sometimes, because there's sort of a feeling, oh, where does this start to veer into you know, medical responsibilities. And I think the other piece is we haven't figured out how to is really the supply chain, and how to get these out into the communities that potentially need them the most. Things are starting to change in Kenya with supply chains. It's becoming very much, there's many more opportunities to get these out. I think, you know, I mentioned drones earlier. That's just one of many ways that things are changing. But understanding the actual physical logistics of getting things to people where they are, who do you best link with? Is it a community health worker? Is it a community leader? Is it a local pharmacy? You know, and then there are multiple sort of steps to that, to even getting it there. And then of course the awareness that it's available and it's consistently available, which is the other problem.
It's great, thanks. Do any of the other panelists want to respond on really helping to make self-care tools and technologies more available as part of a primary healthcare strategy?
I'll just add to that, and I would say from the side of tech development, more and more technologies are being designed to be simpler. We could look at things like rapid diagnostic tests for even fever, malaria, being available to community health workers as a pathway to facilitating self-care. And in some areas, that beginning stage of someone screening themselves, even using digital tools to narrow down to what potentially the cause is before they seek healthcare, and then those tools direct them whether they actually need to access care. I think those are ways of facilitating self-care in that it's just on a spectrum of what care options are, by pushing the simpler things, being screened early, and direction to the right place to get treatment when there's need. So I would say, like with some of the diagnostics too, we see more self-sample collection by patients as also the way lower basic aspect of them to contribute to self-care.
That's great, thank you. Any other responses on this question? If not, there was the the perennial question that's always asked around financing and how we can do a better job of financing primary health care. And Minister Leah, you talked about financing primary health care in Ethiopia. Any additional thoughts or words of wisdom for other countries, other advocates around the financing piece would be welcome.
Maybe to just add a few points. I think that's one of the big challenges we have in all of our countries, in terms of course, the resource itself, but also the how part of how we channel funds and how we finance our systems. So we have been trying to look into, of course, primarily increasing investment to health is one of the key agenda of I believe many countries. When you look at the expenditure out of the total government expenditure, the percentages are still very low. For us as a country, we are around 8.5, which at least we all know we at least try to achieve the 15%. So as we continue to advocate for more resources and showing that investing in health is not an expenditure but an investment itself, because of its many returns. So it should be seen as an investment. So that's one aspect of continuing to advocate for more resources, but also for governments to invest more on primary healthcare. But then, of course, the financing aspect of it on the how part. One of the big challenges for us has been we have a large part of our health services being subsidized and exempted, covered by government funds, but also donor funds. But really bringing sustainability and quality of care with such approach is very difficult. That's how we started the national the health insurance system, the community-based health insurance, which we are now moving to the social health insurance as well. But also beyond that, in terms of exempted services, we are revisiting on how we deliver services. So as I said earlier, how the strategic purchasing aspect of it, we are piloting performance-based financing, which we are not yet sure if it's the most feasible approach for a country like ours. But we are also looking at capitation financing as well. So the approach of how we finance, where we bring efficiency, motivation, and quality of care in the facilities, where they can continue to improve their quality of services. So continuous supply chain, but also motivating health workforce. So the finance is a key foundation for this. And we are also looking at a country level in terms of increasing funds for health beyond government and donor resources, looking at other innovative financing mechanisms by trying to establish health funds, which can be a way to where many contributions from other private sector and others can be there. In addition, we're advocating for channeling more funds from excise tax, which is being collected for some of the harmful products for health to be channeled to health. So we're looking at different approach for sustainable health financing, because we still have high out-of-pocket expenditure, high funds coming from donors, which are continuing to decrease. And we need to have a sustainable way of really domestic financing. Thank you also.
Thank you. That was a brilliant response, and we really look forward to learning more from you implementing all of those different interventions related to health financing. But fundamentally, as you say, investing in primary healthcare is an investment for the whole population. So with that, I wanted to ask the panelists if there's any one rapid takeaway that you have that you want participants to take with. It could be a call to action or another key point that you have in mind related to primary healthcare and innovation. So I'll start with you, Dr. Julian.
So I'll end by saying that at GH Labs, we believe that everyone everywhere deserves the healthcare they need to thrive. And on our side, we believe expanding access to quality primary healthcare services is a key step to the path towards UHC. And that is why, as GH Labs, we work towards contributing to this vision by developing tools and technologies that are responsive to the unmet needs in order to leapfrog some of the barriers that have been hindering access to quality primary healthcare.
Great. Excellent. Thank you. Over to you, Minister Leah.
Thank you. Well, I think my takeaway is the heart of our investments should continue to be our primary healthcare. And when we say invest, of course, it has to be a comprehensive way where we are addressing quality, not just access, but also quality and equity, addressing all kinds of communities, and also the use of innovations beyond. One is, of course, digitization, but also beyond digitization. We're looking at innovative ways of addressing the needs of our communities, making it close, looking at other different technologies that can make it easy to access care for our communities so that we are much closer to our communities.
Wonderful. Thank you. And over to you, Mayank.
So the point I wanted to raise has already been mentioned by Her Excellency about PHC being the strong foundation. But I'll also want to add that UN Secretary General had once remarked that innovative forms of knowledge exchange, technology transfer, and emergency response and recovery of livelihoods led by South are transforming lives. So I believe accelerating progress towards universal health coverage also means strong South-to-South collaborations. Thank you.
That's great. Thanks, Mayank. And over to you, Radha.
Thank you. My call to action is really around innovation and technology, which may sound a bit funny coming from someone who's working in the tech space now, but I think we need to be really thoughtful around where innovation and technology really exists to move the vision of primary healthcare forward, not investing or spending time on it just for the sake of it or because it excites us to say something is innovative or new, but because it's really moving the goalposts of comprehensive, care for everyone. As long as we keep our lens on that, I think we'll really achieve what we're out to do.
Thank you so much, Dr. Radha. And a huge thank you to our panelists. Thank you for your wisdom, your brilliance. It's really exciting to see the ideas that are being put into action to really innovate and think about what is primary healthcare of the future that will get us to universal health coverage by 2030. So huge gratitude from Path and from myself. Thank you so much for spending your time with us. And thank you for our audience and participants for the wonderful questions. So with that, I'm wishing you a wonderful day or evening ahead. Thank you so much.